sharing your story. It's inspiring, and for being vulnerable. It helps us to understand how we can better communicate with our patients. Okay, so thank you guys for inviting me here to talk about a topic that's really, really close to my heart and close to my soul. And this is who I am, but I will start by saying that earlier this year, I actually started essays that I write on my Substack, and it's called Soul to Soul Leadership. And the reason I'm telling you this is because these are titles, and one of the most impactful essays that I wrote earlier this year was called Soul to Soul and Not Role to Role. We frequently come to situations with our roles and our titles and all these things we stand behind, instead of bringing the humanity and the soul. And so, regardless of what this says on the screen, I'm being very vulnerable here with you guys because I'm bringing my soul. This is very, very important to me. I have no disclosures related to this presentation. So, how many of you have heard that phrase, "because I said so," as a child? I know I have. It meant the conversation was over, the adult had spoken, your questions didn't matter, your understanding was irrelevant. Compliance was all that mattered. And you know what? Sometimes that worked. As children, we couldn't always grasp the complexity. Sometimes authority had to be enough. But we're not children anymore. And our patients aren't children either. Yet somehow, despite decades of rhetoric about shared decision-making, frameworks about patient-centered care, and everything we know about behavioral change, our communication in lung cancer still carries echoes of "because I said so." I've spent more than 2 decades as a nurse practitioner and behavioral scientist, studying what happens in the space between what we say and what patients hear. And I can tell you this with absolute certainty. In lung cancer, that space is killing people. Not slowly, not theoretically, not in some distant abstract way. Right now, today, in our clinics, in our research labs, in our advocacy space. So let me give you some numbers. Not the efficacy data, we all know that story. I want to talk about what happens after, or rather what did not. In that same time period, breast cancer screening rates climbed to 80%. Colorectal cancer screening reached 70%. Lung cancer screening, depending on which data source you trust, somewhere between 5 and 19%. So let's be generous, 18%. 18%. And before we blame access barriers, which are real, let me tell you what the research shows. Among people who have insurance and are eligible for screening, uptake rates remain devastatingly low. In a study by Hughes and colleagues, less than 5% of those who were both eligible for lung cancer screening and insured were actually screened. More than half of people who are eligible for lung cancer screening have never even heard of lung cancer screening, 14 years later. Even among those who gain Medicare when they turn 65, which essentially removes that access barrier related to insurance coverage altogether, more than 3/4 still don't get screened. Access is not the only barrier. Cost is not the only barrier. Awareness is a massive barrier. Stigma is the barrier, and we built it, word by word, message by message, silence by silence. In our recent work, using the Lung Cancer Stigma Communications Assessment Tool, we found stigmatizing language in 83% of patient education materials we reviewed. 83%. These aren't materials from the 1950s. These were current, well-intentioned, evidence-based materials created by people who care deeply about lung cancer, by us. Let me take you inside a moment that happens every day, a real moment that happens every day and across this country. The setting is a primary care office, an annual exam. The provider has 15 minutes. The patient is 58, has smoked for 30 years, quit 5 years ago. This is what the clinician says. Given your smoking history, you meet the criteria for lung cancer screening. It's a low-dose CAT scan, and it only takes 10 minutes. You don't have to get undressed, there's no IV contrast, and studies show it decreases mortality by 20% through early detection. I strongly recommend it, and we can schedule you today. Perfect, right? Evidence-based, compassionate tone, clear recommendation. This is exactly what we teach. Now let me show you the translation. You said, given your smoking history, the patient hears, you screwed up and now you're paying for it. You said, you meet the criteria. The patient hears, you're in the cancer risk category, the damaged goods category. You said, screening. The patient hears, we're looking for the cancer you probably gave yourself. You said, I'd strongly recommend it. The patient hears, because you're too irresponsible to decide for yourself. And finally, you said, we can schedule you today. The patient hears, we need to catch this quickly because of what you did. That's not paranoia. That's not misunderstanding. That's not health illiteracy. That is 50 years of public health messaging that framed smoking as a moral failure. That's a lifetime of just quit or you should have known better. That's every news story about lung cancer that led with the patient was a smoker. That's the absence of pink ribbons and awareness months and celebrity spokespeople. That is the silence. And here's what the translation costs. The patient says, let me think about it, and never comes back. Or schedules the scan and doesn't show. Or shows up so anxious that they cannot complete the scan. Or worse, gets a positive finding and then delays follow-up because they feel they deserve whatever's going to happen to them. We call this non-compliance. I call it survival. So let me tell you about two people who changed how I understand this work. This is Maria. She's 58 years old and has worked as a home health aide for 30 years. She raised 3 kids alone and has smoked since she was 16. She started because all her friends in high school were smoking, but she continued because it was the only break that she got in her 14-hour days. She came to the clinic with a cough she had had for 8 months. 8 months of waking up at night, 8 months of her daughter begging her to go get seen, 8 months of knowing. When her doctor asked why she waited, she looked her straight in the eye and said, I knew what you'd think, that I did this to myself, that I deserved whatever happens. And I couldn't face that, not yet. I had to be stronger. She was diagnosed with stage 4 lung cancer, and 6 months later, she was gone. But here's what should haunt us all. Her doctor never thought that about Maria, not for 1 second. She saw her resilience, her strength, her devotion to her family. She wanted to save her life. But Maria didn't know that. Because somewhere between all the public health messaging and campaigns and medical advice and cultural narratives, she learned that people like her, people who smoked, were not worth saving. And that belief killed her more surely than the cancer. This is James. He was 63 years old, a Vietnam veteran, never smoked a day in his life, diagnosed with stage 2 lung cancer. Every single person who found out, family, friends, his colleagues, all asked him the same question. Did you smoke? He told me, I started saying no, really aggressively, like no. Like I was defending myself. Like I had to prove I was innocent. And then I'd feel guilty for feeling relieved that I could actually say no. Like the people who couldn't say no somehow deserved it. Think about that. Lung cancer creates 2 tiers, even among patients, the innocent victims and the guilty ones. And we reinforce it every time we lead with the smoking question. Every time we have separated people who smoke from people who never smoked in our research without acknowledging what that separation actually implies. Let me show you the data on what stigma actually does. Our research team, along with colleagues across the country, including in this room, have systematically documented the impact. At the screening stage, people who perceive higher lung cancer stigma are significantly less likely to engage in screening discussions with their providers, and less likely to complete screening, even when it's recommended and accessible. The effect size is comparable to not having insurance. At the symptom onset stage, people with a smoking history delay seeking care for lung cancer symptoms an average of 4 to 6 months longer than those without a smoking history, even when the symptoms are identical. That delay could very well mean the difference between stage 1 and stage 4 lung cancer. After diagnosis, people with lung cancer reports experiencing stigma more than patients with any other type of cancer. That stigma predicts worse psychological outcomes, decreased treatment adherence, and reduced social support, all of which ultimately impact patient outcomes and survival. And here's the kicker. Stigma is highest among people who currently smoke, exactly the population that's in greatest need and in most need of screening. We have created a perfect storm where the people who need our interventions most are the least likely to access them because of how we talk about them. So here's a framework I want you to take with you. Every clinical encounter about lung cancer actually contains 3 simultaneous conversations. Conversation 1 are the clinical facts. This is where we're experts. Risk assessment, screening guidelines, diagnostic pathways, treatment options. We can do this in our sleep. But conversation 2 is the emotional subtext. This is what patients are actually listening for. Do you see me as a person or a risk factor? Do you blame me? Do you think I'm worth saving? Can I trust you? Will you judge me? And conversation 3 is the decision architecture. This is the internal dialogue that happens after we leave the room. Can I handle this emotionally? What will people think? Is there hope? Am I strong enough? Will this be worth it? We've mastered conversation 1. We are brilliant at it. But if conversation 2 goes wrong, if the emotional subtext is shame and blame, conversation 3 never ever happens, or it happens in the wrong direction. Perfect clinical information delivered into a space of stigma creates 0 behavior change. So I'm going to give you a practice tool right now, a before and after comparison you can use immediately. Stop saying, smokers are at higher risk. Start saying, people with a smoking history may benefit from screening. Why? Because smoker is an identity label. It reduces a complex human being to a simple single behavior. People with a history of smoking acknowledges both the person and the history without making it their defining characteristic. Stop saying, your risk is elevated because of your smoking. Start saying, screening is available to you and early detection can be life-saving. Why? Because leading with risk reinforces fault. Leading with opportunity reinforces agency. Stop saying, why haven't you quit smoking yet? Start saying, what would support you in either reducing or quitting tobacco use, if that's a goal you have? Why? Because why haven't you implies failure and judgment. What would support you implies partnership and possibility. And stop writing, participants were categorized by smokers or non-smokers. Start writing, participants were categorized by smoking status. Why? Because every research paper that uses smoker and non-smoker as demographic categories reinforces the stigmatizing binary. We can be scientifically precise without being linguistically harmful. To the primary care physicians in this room, you have 15 minutes and 17 things to do. I totally get it. But here's what I'm asking. In the 90 seconds you spend discussing screening, add 10 seconds of translation. Before you say you're eligible because of your smoking history, pause. Look them in the eye. Say, I want you to have every opportunity for early detection. That's it. 10 seconds. It can save a life. To the pulmonologists and thoracic oncologists in this room, you're having the hardest conversations. The I found something conversations, the it's cancer conversations. In those moments, please, please, do not let the first question be about smoking history. Lead with, I'm here with you. Lead with, we have a plan. Get the smoking history later if it's clinically relevant. But don't make it be the first thing that stands between you and the patient's ability to hear anything else you say after. To the researchers in the room, and I'm looking at me because this is a paper I wrote in 2017, and the second word in that paper title is smoker. We need to revolutionize our terminology. Not next year, not in the next grant cycle, in the next paper you write. Stop using smoker and non-smoker as categories. Use current smoking status or smoking history. Stop writing abstracts that say screening uptake was lower among smokers without acknowledging that the stigma we perpetuate may be why. Include stigma measures in your protocols. Study communication as rigorously as you study biomarkers. Because if stigma is preventing people from screening what we do, accessing what we discover, our discovery is functionally useless. To the advocates and communicators in the room, use the LCS cap on every campaign, every message, every image. Ask, does this language blame? Does it label? Does it oversimplify? Does it reduce people to their risk factors? And if it's yes to any of those, rewrite it. And please, fight for lung cancer to be treated with the same dignity and compassion as every other cancer. I am speaking to the choir in this room. To the survivors and caregivers in this room, your presence here is radical. Every time you show up, you are dismantling stigma just by being visible. Every time you tell your story without shame, you're giving permission to others to seek care without shame. Keep showing up, keep speaking, because your voice is changing this field in ways that our data never will. So I want you to try something this week, an experiment in translation. Take one thing you say regularly, a phrase in your clinic, a sentence in your research, a message in your advocacy work. Just one thing. Now, I want you to imagine that you're the patient that's hearing it. Not as you, educated, medically literate, secure, as a patient who has spent 30 years being told they lack willpower, who's been blamed by family members, by society, maybe even prior doctors, who is exhausted and scared and barely holding on to hope. What do they hear? If that answer makes you uncomfortable, good. Sit with it, stay with it. That's where the learning lives. Then rewrite it, say it differently, remove the blame and add the humanity. Test it on a colleague, better yet, test it on a patient advocate or a survivor. Ask them what they hear. That's the work. That is how we change things, that's how we close the gap, one phrase at a time, one conversation at a time, one moment of translation at a time. So let me paint you a picture of what's possible. It's 2035, 10 years from now. A 58-year-old woman walks into her doctor's office for her annual physical. She has 30 years of smoking history. The doctor says, I want to talk to you about lung cancer screening. It's a quick CAT scan that can catch cancer early when it's most treatable, and you're eligible. And I think it's a good idea. What questions do you have? The woman doesn't flinch. She doesn't brace for judgment. She asks practical questions like, how long does it take? What happens if you find something? Is my insurance going to pay for this? She schedules the screening. She shows up. They find a small nodule, stage 1A, resection. She's cancer-free. This happens not once, but thousands of times, because we changed the translation. In this future, lung cancer screening rates match colorectal and breast cancer screening rates, maybe even surpass them. Stage 1 diagnoses become the norm, not the exception. 5-year survival rates climb to 60%, then 70% and beyond. People with concerning symptoms seek care immediately because they're not afraid of what we're going to think of them. Research participation soars because people don't feel like they're being studied as a moral failure. Lung cancer advocacy draws the same public support, the same funding, the same compassion as every other cancer. And stigma becomes a historical footnote, something we look back on with disbelief that we now think of as like bloodletting. That future is not a fantasy. It's a choice, and we're choosing it right now in this room. Remember where we started? Because I said so? That's the old model. Top-down, authority-driven, one-way information transfer. And maybe there was a time for that, and when it worked, when paternalism was expected, when patients didn't have access to information, when compliance was the goal. But that time is over. It's actually been over for a long time. And in lung cancer, where every ounce of authority gets filtered through decades of stigma, it's not just ineffective, it's deadly. We need a new model, one that sounds like this. I see you, not your risk factors, not your pack years, not your diagnosis, you. And we're gonna figure this out together, because you're the expert in your life, I'm the expert in medicine. You deserve screening and care and hope, not despite your history because that's irrelevant, but because you are human. Your life is worth fighting for, and I'm here to fight for it with you. That's the translation we've been missing. That's the bridge, the connective tissue. That is the gap we need to close. Now I want you to take 4 specific actions, not suggestions, not considerations, actions, things you're gonna do. Action 1 is the language audit. This week, not next month, this week, audit one piece of communication that you own and control. A patient handout, a research abstract, a campaign message, and use the LCS CAT. Find the stigmatizing language and rewrite it. Done. Action 2 is the translation practice. Before every screening conversation, every diagnosis disclosure, every research consent process, pause for just 5 seconds. Ask yourself, what will they hear? Not what am I saying, what will they hear? And let that guide your words. Action 3 is the solidarity commitment. When you hear stigmatizing language from a colleague, in a presentation, in a paper, say something. Not in a way that shames that person, but in a way that shifts the norm. Something like, I've been learning about how language impacts patients. What if we said it this way instead? That's how cultures change, through small, consistent acts of redirection. And action 4 is the amplification promise. Find one patient voice, one survivor story, one advocacy effort, and amplify it. Share it, fund it, platform it, make space at your tables, because we never fully understand what patients hear until we let them tell us. I think about Maria every single day. I think about month 1 of her cough, when intervening would have been simple and straightforward. I think about month 4, when she almost made an appointment, but talked herself out of it. I think about month 8, when she finally came in and the doctor saw the look in her eyes, shame mixed with resignation, as if she was accepting some sort of punishment. And I think about all the future Marias, who are sitting in their homes right now with coughs that won't quit and fears they can't voice, trying to work up the courage to face what they assume will be our judgment. We can't save Maria, but we can save them. Not with new drugs, not with better imaging, not with more guidelines. With our words. With language that invites instead of indicts. With communication that translates clinical reality into human hope. And with conversations that close that gap between what we say and what patients hear. You didn't come to this meeting by accident. You're here because you care. Because you've dedicated your career, maybe even your life, to fighting lung cancer. You've published the papers, run the trials, treated the patients, advocated for change. You've done hard, brilliant work, life-saving work. And now I'm asking you to do one more hard thing. Change how you talk. Not because it's politically correct, not because it's nice, not because someone told you, although I think I am actually telling you from the stage. Because it will save lives. Because the gap between what we say and what patients hear is not a communication problem. It's a survival problem. Because communication is not neutral. Because we are not just clinicians and advocates and researchers, we are translators of hope. And when we stand in that space between what is known and what is feared, between diagnosis and decision, between despair and possibility, our words are the bridge. So let's build better bridges. Let's close the gap. Let's replace "because I said so" with "let's figure this out together." And let's do it now, not next year, not in the next grant cycle, not when we have more time, now. Because somewhere right now, there is a Maria. She has a cough, she knows something is wrong, and she's trying to decide whether or not to call her doctor. And what she decides will depend in part on what she thinks she's going to hear when she does. So let's make sure what she hears is hope. Thank you.